Hey, good evening, everyone. My name is Mark Cannon, and welcome to Fireside Chats. Again, before we introduce our guest for the evening, why Fireside Chats? Well, let's talk about Fireside Chats for just a moment. Fireside Chats were a series of radio addresses done by U.S. President Franklin Delano Roosevelt from 1933 to 1944. They were meant to actually garner support for his political agenda, but eventually people look to it as a source of hope, inspiration, and that's what we're trying to do with this. We want to have us be inspired. We want to encourage people to work to better the health of all individuals, of all of our patients. We want people to come on the program, share their challenges, share their source of courage, and discuss the newest advancements in their field of endeavor. We're very pleased that tonight our guest is Dr. Irina Troostman, MD, and we hope the topic will not keep you up all night. Oral health and pediatric sleep apnea, collaboration between health professionals, the present and the future. So a little word about our guest. Dr. Irina Troostman is a graduate of the University of Chicago Pritzker School of Medicine. University of Chicago is that place south of Northwestern, a little bit further south, a little bit further in from the lake. It's not as close to the lake as Northwestern. And the University of Chicago Pediatric Residency Program, as everyone knows, there's a little bit of competition between University of Chicago and Northwestern University. She received additional training in sleep medicine at the North Shore Sleep Medicine Center. She's been part of the Lurie's Children's Hospital sleep team for almost 15 years. As a side note, I started at Children's Memorial Hospital in 1978. Yeah, I was a child prodigy. I had just turned about 5 at the time, obviously. In addition to an extensive educational experience with medical students, residents, and fellows, Dr. Troostman has been collaborating with her sleep medicine colleagues from all over the world. Otolaryngologists, developmental pediatricians, neurologists, dentists, pediatric dentists, psychologists, and orthodontists. Dr. Troostman presented at numerous national pediatric sleep medicine conferences. I don't know if it's numerous, but at national pediatric sleep medicine conferences. Shouldn't add words in there. I did. Pediatric American Thoracic Society meetings, grand rounds, pediatric conferences, and notably at the Chicago Dental Society meeting in 2022, was it? Yep. It's I'm so proud of you doing that, by the way. Thank you so much for being there at the Chicago Dental Society. She is currently involved in clinical research and building interdisciplinary clinics for pediatric patients with sleep disorders. Dr. Troostman is a board member of the Illinois Sleep Medical Society and co-chair of the Pediatric Committee. And as an important personal note, Dr. Troostman is a former fencer and resides with her family in Bernedoodle in Chicago. I was a former fencer too. I spent most of my time putting up stockade fences on hot August days. Now, kidding aside, that was one of my many little jobs, was putting in fences. Not exactly the most pleasant work when it's 100 degrees outside and you're carrying around heavy lumber and putting in posts and all that. Well, thank you so much, Irina, for joining us tonight. As you know, this is part of the American Academy for Oral and Systemic Health, and we're all about the collaboration and working closely with all other health professionals. And I always tell people that I don't have a hard time communicating and working with my medical colleagues because, again, I got started doing that in 1978. I started my residency, and I did that before I did my residency, and I always feel it's very natural to do so. So tell us a little bit about yourself. Where are you originally from? I mean, you seem like a Chicago person.
Well, indeed, I guess I spent first of all, thank you so much for inviting me. It's an honor and I appreciate it. I'm originally from the former Soviet Union, so believe it or
Mhm.
not. And yeah, I've been since '94. So I spent half of my life here, and I'm very proud of it and very happy. So I'm very grateful to the country and the people, and would never want to go back.
I get that from a lot of my, Chicagoland has a lot of people formerly from Russia and also formerly from the Ukraine. And I have a lot of very good friends who tell me the same thing. They're so happy to be here, and we're happy you're here too.
Thank
Very,
you.
very happy you're here. So, what got you started? I mean, you went to medical school, and all of a sudden, you couldn't sleep one night and said, "I got to go into sleep medicine."
You probably remember your residency days or nights, sleepless nights, pagers going off, the relentless calls. So sleep deprivation was quite powerful, but I didn't really know anything about sleep medicine at the time. I didn't even know that such specialty existed. Having said that, there was a sleep center at the University of Chicago, and I cut through the building because the pediatric hospital was part of the adult hospital at the time. And I've noticed it's quiet and there are very inviting rooms. And all I wanted to do is just to crash somewhere there and take a nap. So I guess I realized that there's a sleep center. I just didn't realize there's such a subspecialty. But I did really get interested in sleep medicine, ironically, as my husband and I were traveling for our honeymoon, and we took an airplane. It was an overseas flight, and there was a
Mhm.
gentleman who was consistently falling into the aisle, and I rushed to him as the resident, of course, full of energy, trying to resuscitate. It turned out he was just experiencing apneas, and he was snoring loudly, and somewhere in between snores, there were like 10-15 second pauses. That's what prompted me to rush to his rescue. Turned out that he woke up and he was startled and he was like, "Lady, what are you doing here?" And I was like, "What is that?" That the person stops breathing and then gasps for air. And so that's kind of sparked the interest. It turned out that one of my former classmates did the residency. After the residency, did the fellowship in sleep medicine and opened her own sleep center. And she invited me just to tour. And I was curious and learned a little bit more from her, and that's what sparked the interest. And then I did additional training. But I have to say, experiencing sleep deprivation, experiencing the effects of sleep deprivation, whether or not as a resident or as a young mom or as a person who used to work 24-hour shifts as a hospitalist, gave me a pretty good idea that sleep is very important. So I guess it was a combination. Sorry for the long answer to your short
No, no,
question.
I love it because actually, that's what drives a lot of us. In fact, I my biggest exposure really was to with my one of my own sons. He had a lot of issue with sleep apnea, and that was over 25 years ago.
Well,
And
interesting enough, yeah,
spurred
I'm
the
so sorry,
whole
but sleep medicine is a relatively young um, area. So yes,
yeah, and that was about 25 years ago, and fortunately, we caught the problem, and it changed his life doing it. But my younger brother passed away at age 59 from sleep apnea. Had
that's
an
so
event at
sorry.
night and died. He was supposed to be on the CPAP. He wasn't doing it. And so that was a very poignant moment in the ICU when his primary care physician said, well, he wasn't doing his CPAP and there was no way he was going to survive from his sleep studies. I knew nothing about him having that bad of a problem. He never shared that with me. But you can talk to a lot of people who have had experiences with someone in the family. I mean, it's a major, major problem. I think awareness is very important on that. So is that what gets you up every morning? Thinking about going in and solving sleep issues?
No, it's actually a cup of coffee and our puppy that get
Yeah,
me
me
up in the
too.
morning.
Sometimes I think I dream about that coffee pot in the morning. I set it on a timer. I, and the alarm goes off. I go, oh my God, thank God the coffee's gonna be ready.
Yes, so
What do we do before caffeine? Honestly. So how do you balance everything? You're so busy now. Are you still? I'm sorry, I really don't know. Are you still interim director?
No, I stepped down in the fall.
Okay.
It was a little bit too much, yes.
Okay.
Speaking of balance, it's very difficult to balance if you want to, and we're short on staff, so it was overwhelming. The
Ah,
administrative duties and clinical duties were just not working together. It was felt like it's too much. I think everybody has
this
its
is
own threshold and when to feel like the balance is off. I felt that sometime in fall, I started stressing too much and I felt that it was too much. So
yeah.
I guess maybe I would have tolerated it a little 10 years ago, but at this point I felt like it was a little too much. And I don't want to sacrifice my patient's care when I feel overwhelmed. So I
Yeah.
definitely felt
Yeah.
like I need to scale back on something. And scaling back on patient's care wasn't an option. So I scaled back on
Yeah.
administrative
I'm always saying
duties.
the same thing. 10 years ago, I could drank those guys under the table. But anyway,
Um,
sorry, it's a bad joke. But
no, I think our tolerance level changes as we
yes. Yeah.
change.
Yeah. So, awareness. Are you finding that people are more aware? What type of effect do you think social media has had with awareness? Are people coming in a little bit more aware that parents are aware there's an issue? Or
Absolutely. So, an interesting phenomenon about maybe 7, 8 years ago, all of a sudden the media was focusing on ADHD and the link to sleep. And we saw a huge influx of calls and requests for appointments because parents wanted to know if their child's ADHD or their kid's ADHD symptoms were related to sleep disruption. So it sparked tremendous interest.
Mhm.
And it was all over TV. I think CNN did a piece. I mean, it was like a domino effect. Once one media outlet started, then the others picked up. So clearly, it has a huge impact on the public awareness.
Yeah, I think it's good because people need to be aware of things. But again, going back to my middle son, we had no idea what was the major problem until finally in conversation with the pediatrician, he said, "I wonder if he's just not more sleep deprived." Because we really didn't have them. I mean, this is 25 years ago. It's not that people didn't know about sleep apnea. We didn't know the prevalence of sleep apnea, and especially in kids. People just thought all that stuff, I think, were just plain normal. So, what would you say is the newest thing coming out right now in studies and in treatment? Is there anything new on the horizon you could predict?
So I think one of the interesting things that probably is going to take off more so in adults and potentially will probably be used in pediatric is something called hypoglossal nerve stimulator.
Hmm.
So it's basically a device that's somewhat, I think that just from my own simplicity, I associate with the pacemaker.
Hmm.
So it's a device that's is implanted by otolaryngologists or ear, nose, and throat surgeons. And it is used for patients who cannot tolerate other treatment of sleep apnea but requires treatment. And the device is working on sending a signal to the nerve that eventually stimulates the muscles of the tongue. And the thought is that by increasing their tone, it keeps the tongue in a more protruded position so
Hmm.
it doesn't fall back. And for those patients who really suffer from sleep apnea as a result of tongue prolapse, it's a revolutionary treatment. And so it's been approved in Europe at first, and then it became approved for adult population. And I think that it will be probably eventually expanded to pediatric population as well, to certain cases. So I think that's one of the big kind of latest breakthrough. I mean, it's been used in adult world, but I think there are now studies showing that it could be used in children with Down syndrome because they frequently have
Hmm.
difficulty tolerating CPAP masks. So I think that's one of the breakthrough. The other breakthrough that not really breakthrough because it's been already on the market for a while is home sleep studies that I
Hmm.
know we may end up talking a little bit later. They've been in use for adults. They actually um, revolutionized our sleep medicine industry, and a lot of sleep centers went out of business once these home sleep studies were implemented. There is a chance there may be some devices that will be approved for pediatrics. We'll see where it goes, but that probably is another breakthrough.
Yeah, I know because I think the sleep image ring has been approved. It's FDA approved for pediatrics also. I've had some experience, with the sleep image ring. I think home sleep apnea tests, the HSATs, will be very important, but there's always going to be room for sleep centers like yours because I always look at those as a screening tool
Yeah,
because
you're absolutely right. That there is probably place for both. I think the reality, unfortunately, and this is kind of off records, is that once the device gets approved, the insurances are very rigid, and they're not going to differentiate. They will create like five items that they will allow children to be exempt from from home sleep studies, and the rest will be automatically rule into this big group. You have to go for home sleep study, and the problem is it's not as simple. Many kids do not tolerate the equipment. We don't expect parents to be at their bedside all night long. The devices are not sensitive enough for kids, and we see plenty of kids with developmental disabilities, and they're not going to tolerate it. So it's a very labor consuming job to perform sleep studies in the lab, because we have technologists who frequently go in and out. They work with the families, they desensitize these kids to the equipment. It's really a very intricate job, and we don't expect parents to be able to do it at home, even with simple devices. But I think there is a place for this technology. It just, a lot of pediatric sleep specialists are a little bit resistant, because once we say okay, it opens this gate for the insurances to say, okay, here we are, and every child will be forced to have a home sleep study, which I think we are not accepting it as a new reality. So I think there's some reluctance on our part, despite some evidence that home sleep studies are certainly acceptable for certain kids.
I know back in 2017 they had that position paper that they were not accurate enough. I don't know if there's been updated
It depends on the devices too. I think there are different, excuse me, different devices. And of course, their accuracy depends on what technology they are using. You probably know that some of them are using nasal signal, others use
Mhm.
pulse and resistance. I mean, others monitor EEG. So the degree of
Yep.
sophistication varies, and I'm sure accuracy does too.
Significantly, they vary a lot. Yeah, I think the problem we are looking at with this is that we have to do what is best for the whole population as much as possible. That's doable for the millions of kids in the United States. And yet we don't want insurance to take away the best mechanism at the same time, the best test. It's really an issue because, again, doing it in the hospital is not the cheapest way to provide any type of care. I'm kind of hoping that somewhere we can find a middle ground. But as you say, with the insurance companies, they're very reluctant to. They're always happy to get the premium. They hate to pay out. They really do.
Right. And the truth is, there are significant differences in how we even approach the workup for sleep apnea. In fact, in kids, you don't necessarily have to have a sleep study. Otolaryngologists frequently use different approach. They just say if you clinically have symptoms and your tonsils or adenoids or both are enlarged, you
Hmm.
probably have it, and it makes sense. And then they will, because the first approach is the surgery. So
Yeah,
they
yeah,
don't necessarily even consider doing this. Or they may consider, but they don't usually force patients to go for a sleep study
right.
unless
You're
there's a
right.
mismatch between what they see on physical exam, or there are some doubts whether or not the exam findings correlate with the history. And therefore, we don't need an insurance to even think about a sleep study or approval of CPAP
Right.
machine. So the cases that are picked up for the sleep studies are very specific. They're not only done for sleep apnea reasons. We do sleep studies for other reasons. But for those who we specifically focus on sleep apnea, those are the kids that, there's something is not matching, or it's a child
Hmm.
with special needs. So it's really complicated, like cardiac transplant. I mean, those are not
Yeah.
just every single child. So as opposed to the sleep studies for adults that were done as a routine screening test on every adult with suspected sleep apnea, we pre-select very carefully the population that needs sleep study to begin with. And for those patients, sleep study in the hospital, even though not ideal, is probably the best option at this point. I wish we had better accommodations and bigger rooms and fancier accommodations. That would be
Hmm.
lovely.
Yeah, it would be. But,
Question.
the hospital did cancel a hot tub project, which would have been very relaxing for the parents.
Our
I'm
parents
sorry.
don't
It's
even have a bed to sleep on. They sleep on the recliner, which unfortunately, I mean,
yeah.
not in every room, but in some rooms. So it's not the best night of sleep for the parents, but usually
No.
they're very grateful anyway for us.
Yeah. I had one of my kids spend 6 weeks in house at Lurie's, and it's very difficult. That's back in the old hospital. It was very difficult to get any sleep or get anything else, rest of any sort.
Yeah.
What would you recommend, though? Let's say you're talking to a bunch of pediatricians. Let's do two groups. Let's look at pediatricians first, then let's look at dentists. What would you recommend that they should look for?
What would they recommend? I'm sorry.
What would you recommend that they should look for? Let's say you got asked by the American Academy of Pediatrics to discuss with pediatricians. Would it be a Brodsky scale? Would it be history? Modified pediatric Epworth sleepiness score? What would it be that you would actually recommend they do? I mean, parental reports, ADHD, Connor's parents rating scale.
There's a very nice scale called BEARS. It's a very simple abbreviation. It goes over bedtime routine, excessive sleepiness, rise time, quality of sleep. So it's an abbreviation that is very simple. And I usually give it as an example. It's a good screening tool. And as we know, pediatricians are limited in time, and there are tons of topics to cover. And so I think that just distributing the scale, and if there are any concerns that come up on the scale, then spending time in exploring. And depending on whether or not it's concerns about child's ability to fall asleep, stay asleep, or not getting restful sleep, or perhaps snoring and all concerns for sleep apnea, then it should be problem focused. And what we see is a variety of problems. Obviously, we see in insomnia, I mean, all of the above. We see sleepiness, we see inconsistent schedule, poor sleep hygiene. So it allows to kind of channel it toward and do target approach. If there are any concerns about snoring, pauses, gasps, restlessness, or non-restorative sleep, I think good physical examination is a must. And it's very quick and simple. You look at the child faces to appreciate if there are any, perhaps some features that suggest that the child's airways could be squished. You may notice that the child is mouth breathing, which is not uncommon when their speech is a little bit more nasal, whether or not they also having nasal discharge, basically runny nose. And you can quickly ask if this is just an acute issue or this is chronic issue. Kids who frequently rub their nose and eyes because they have allergy symptoms, which is another risk factor for difficulty breathing, frequently rub their nose and they have a crease. We call it allergic salute. Or they can have the shiners under their eyes. And then I can't tell you how many times I look at the nose and notice this very swollen nasal passages. The turbinates meaning of the nasal passages is quite swollen. And the parents like, I've never heard of it. My pediatrician never said anything. Or you can ask the child to just close one nostril and take a breath through the other while the mouth is closed and see how much obstruction or how much resistance is to the flow of air. And then, of course, looking at the airways, opening the child's mouth, looking at the roof first. If it seems to be a dome shape, it's reassuring. If it seems to be like a steeple, it's a concern. Many kids who breathe through their mouth have discrepancy in their upper and lower jaw growth. So they develop what we call malocclusion, malalignance between upper and lower jaw, because they're not touching each other for extended period of time. And therefore they have overbite, underbite, crossbite, overjet, all the types of improper, and you can probably correct me if I'm wrong using
It's okay. It's okay. Yeah.
But all
We
of
know
them.
what you mean. Yeah, we know exactly what you mean. Yeah. And the same thing for dentists too, right? I mean,
Absolutely.
you
When I
gotta look at the occlusion.
and to your point, when we talk to the dentist, we always ask them to look at not just focus on the face, but also look at the other cues. And of course, look at the tonsillar size. Now, we know that tonsillar size it's not the best estimate. It just kind of raises your awareness, but it doesn't necessarily mean the child has sleep apnea. But I think in conjunction with history that may suggest sleep apnea, such as snoring, restless sleep, sweating during nighttime, and so on, it would make sense to at least point it out and say, by the way, I noticed that, or your child is chronically mouth breathing. Have you looked into the nasal passages? Has anyone ever talked to you about why your child may be mouth breathing? At least raising the awareness, I think, is very important. And it's amazing how many health professionals don't do it.
No, you're absolutely correct. It's amazing. Or even one thing you didn't quite mention, I think maybe you alluded to or were going to, was bedwetting too. And you have these patients who have all these symptoms, and then you ask, well, what has the pediatrician said? And the parents will give you a blank look, like you mentioned. And I haven't been told anything. And they go, well, okay. I spend a lot of time calling up pediatricians and say, hey, I think we may have an issue here with a little sleep apnea. And we go forward with the plan. I hope you're getting a lot of these referrals, by the way, because I often suggest that they go to the sleep center and get a sleep study done, but I don't know how far they ever get with it. I don't often get reports back. So I'm kind of leery of making any judgments on the percentages, because I just don't know if they're going to the pediatrician who then says, don't worry about it. They'll outgrow it. They'll grow out of this soon.
We've heard that too. So the biggest, so we probably get about 50% of our referrals to the sleep studies from the outside physicians, and therefore, because we have an open laboratory sleep lab, therefore we may never see these patients for consultations. They would come for a sleep study. Their report will go to their referring physician, and then it's up to the referring physician to decide if the child needs to be seen by a sleep specialist. So we probably don't see a big bulk of these patients, but if we pick up a very severe study, we pick up the phone, we call the referring pediatrician, say, get this kid to us or to ear, nose, and throat. Let us know if we can help, because it's really concerning. So we sometimes solicit the referrals.
Now, there are so many little dental symptoms that are associated with it too, like sleep bruxism. There's a higher percentage of kids who grind their teeth at night. And of course, one thing we didn't really bring up yet, and we should, the amount of oral disease. That should be automatically a red flag for dentists. But you were going to say something. Go ahead, please.
No, you're right. If we get this question about teeth grinding or bruxism, interesting enough, recently I was looking at the updated guidelines from the American Academy of Sleep Medicine. We're not supposed to say bruxism anymore. We just say excessive mesenteric activity was observed during the sleep study, presumably because it doesn't always translate into clinical teeth wear. And so they only want to have a combination of physical exam findings as well as the sleep study findings. But we do see excessive mesenteric activity. And I have to say, I haven't seen any official studies, but we see it in a lot of kids who just sleep poorly, not necessarily kids with OSA or obstructive sleep apnea. We see it in kids who are anxious. We see it in kids who just had a poor insomnia, ADHD, worries. So I don't know if the sleep-related bruxism is pathognomonic or like a landmark of a sleep apnea. I think we could be like bedwetting, but also bedwetting could be an isolated symptom of other things, or it could be just an isolated finding.
There was a good study out of Chile on that, actually looking at how you could, in some patients, the sleep bruxism in these kids was related to the sleep apnea. But in other kids who had sleep apnea or sleep disturbed breathing did not have sleep bruxism, but they had another symptom like ADHD. So they could go different directions, the kids with sleep disturbed breathing. It was a very good study. And it kind of shows that you can have an initiator that has different effects down the road. They don't all have, the initiation doesn't have to have the same effect. We see that in healthcare so often. You have different results from a nutritional deficiency, for instance, that they often didn't even think about in the past. What usually becomes the treatment
for sleep apnea in kids?
Yeah.
It's not anymore as clear, to be honest. So the extreme cases, the severe cases, when the child is experiencing frequent episodes of difficulty breathing, are a little bit more straightforward. We're really worried about these kids, and we really send them to ear, nose, and throat doctors as a first step. And if surgery is indicated, meaning they have large tonsils and adenoids and there are no contraindications, they usually get them out. In severe cases, sometimes it's not sufficient. Sometimes these kids still have sleep apnea, and ear, nose, and throat doctors have other surgeries in there under the belt. But then usually these kids come to us to explore non-surgical treatments. And in some cases, it's really weight. And we unfortunately see so many obese patients. And sometimes ear, nose, and throat doctors are reluctant to take them to the surgery because they're worried about risk of anesthesia and postoperative complications, and would rather manage them conservatively. Those are more extreme cases. And sometimes bariatric surgery is the way to go. That's assuming the child doesn't have large tonsils and adenoids, is mostly weight. When we talk about patients who have non-severe cases, that becomes a little bit more of a gray area. It used to be that surgery was still, by surgery I refer to adenotonsillectomy, used to be a number one choice. But then there was, in 2013, it was kind of a breakthrough study called CHET study. And it was the first study where the group of kids was randomized into observation group and the surgical group. And the groups were compared as far as their baseline severity, baseline cognitive testing, a whole bunch of neuropsych evaluation. And then one group underwent surgery. The other one was more like conservative treatment, nasal spray, saline spray, maybe nothing. And then 7 months later, they were compared. And the primary goal of the study was to show that surgery, the adenotonsillectomy that was classically gold standard of care for decades, is really the way to go, that it not only improves the severity of sleep apnea, but improves concentration and cognition and neurodevelopmental outcomes. Because all the previous studies were mostly retrospective, and therefore they lack a lot of, they were inconsistent, use different parameters, and so the data wasn't best. And what was shocking, that despite better outcomes as far as severity of sleep apnea in the intervention group, meaning their severity scores really dropped based on the sleep studies, the neurocognitive outcomes did not dramatically, the primary outcome hasn't changed. So everybody was a little taken back. And of course, there are a lot of speculation. Maybe the study wasn't perfect. Maybe it was a little bit older kids, but what about younger kids? But it raised a lot of good questions. Whether or not every child with sleep apnea needs to go for a surgery. What was also interesting, you found that some kids have full resolution of sleep apnea within this 7-month period and without any surgical intervention. And so now we're scratching our heads thinking, oh, does every child need a surgery? Which one will respond to in non-surgical observation? How is it ethical to wait for 7-9 months? In the meantime, the child may be suffering disruptive sleep. And back to your point, what was interesting and what was also very peculiar and was outlined by many publications by David Gazelle and his group, who he's one of the biggest names in the field of pediatric sleep apnea, that some kids with the same, a group of kids with the same severity of sleep apnea may have vastly different presentations. Some may be completely asymptomatic and have undisturbed sleep. Others could have significantly disturbed sleep. Others could have more daytime disruption. So it's probably a combination of genetics, in addition to severity of sleep apnea, as well as other environmental factors, comorbid conditions, other medical conditions that the child has, that probably impact how sleep apnea effects manifest or don't manifest in this particular child. And what we now think that it has to be really customized approach. It's not the severity of sleep apnea alone that should really dictate which way we go. It's really more, what is this child's risk factors? How much sleep apnea is really impacting his or her sleep, and whether or not it's time to intervene. So we're now on a different path. Instead of sending everyone to the surgery, we're doing more customized approach.
Well, that's wonderful, because as you mentioned, David Gazelle, whose name comes up all the time, and a prolific researcher, and he's very highly respected by everyone, has brought up the fact that with some of these, like if you do the animal studies, the neurocognitive damage is done quite early, it'll never go away because it's done. And that is kind of shocking and surprising because it means that sometimes we missed the boat before we knew the boat was leaving. I mean, it's really a sad situation. And yet we have other reports like Dr. Julie Way. Oh, she was a Lawrence Hollinger Fellow and ENT at Lurie's, by the way, had done this little pilot study with 20 kids who are going to have their tonsils and adenoids removed because of sleep issues. And they put them on not a very restrictive, they put them on a restrictive diet, removing a lot of typical junk processed food. And their tonsils and adenoids, I think in 17 out of the 20, shrunk significantly without the need of surgery, which was a very big surprise to her. But when we think about how bad our junk food is, all the colors and the preservatives are probably all irritating to adenoidal tissue. And, that could be one of those confounders. Don't you love confounders? There are so many little variables you always have to take in consideration when you do a clinical trial.
Yes, and who knows, some of these kids, and I haven't seen the study, I have to admit, but some of these kids probably became leaner without junk food. And another point that we've learned relatively recently over the last decade or so, that it's really very complex mechanism. It's really not just the size of the tonsils, the size of the adenoids, it's the size of the airways, how collapsible they are, how much extra tissue is pushing on them. And so with the same size of the tonsils, one child may have full sleep apnea, other won't. So it's not, again, it's a very complex, intricate mechanism of an interplay of anatomic and structures and functions. So again, if they became leaner, it's possible that perhaps the diameter of the airways was a little bit bigger. And
no, there's all sorts of possibilities.
It's a possibility that multiple factors improved. But we also know that there's inflammation. I mean, we clearly know, interesting enough, that some kids, there are evidence of inflammation in the upper airways. In fact, in asthmatics, there's a high risk of sleep apnea because they have inflammation stretching from lower airways to upper airways. Kids with allergic rhinitis, the inflammation goes from nasal passages to upper airways. So clearly, if somebody's eating food that causes inflammation, possibly.
Yeah, and we do know that. Oh, we started to talk about oral disease because there's been shocking literature out there. One of the things that Dr. Julie Way brought up is when they have these kids with the airway issues and they're a 4 or 5-year-old, and she goes, you look in there, you see obvious decay. You see abscesses. And there was a recent report in the International Journal for Pediatric Otolaryngology where they looked at a large group of kids who are having tonsils and adenoids removed for sleep apnea purposes. And 90% of them had severe maxillary gingivitis, and about 80 some odd percent had obvious decay. So in fact, 62% had severe decay. And she kind of rails about it a little bit because she feels that these poor kids are suffering from so many factors, and yet no one's treating that. I mean, it's sadly because where she's at, there's a lot of patients on Medicaid, and there's very poor dental coverage. So they're not sleeping, and they have huge tonsils and adenoids. They also have 2 abscessed teeth at the same time. I mean,
so do you think it's a result of a chronic mouth breathing that causes dental abscesses, or it's a combination of poor dental health?
Oh, yeah. There's actually excellent research published on mouth breathing and change of the oral microbiome, and also would be with the nasal microbiome too, which is actually, it's kind of a vicious cycle because, we did that, at Northwestern, we just completed about a year ago now, the first whole genome deep sequencing of the nasal microbiome in healthy individuals. Actually had never been done before, which you're going to be very surprised. Our ENT colleagues had not completed that. It was very surprising to find out the number of, we got about 2,553 strains that were very evident in healthy individuals. And a lot of probiotic strains that are actually help keep the airway open. If the nasal airway is now open, you got a major problem. And that's why I'm kind of hoping that one day we'll have some, you mentioned nasal sprays earlier, that will have some type of major benefit with knowledge in nasal sprays, and we'll even have a nasal spray probiotic. That's one of my dreams. I'll open up the nasal airway, help. But that only works if you have a good skeletal structure, you have a good maxilla, and doesn't work if everything else is out of position, though.
We see so many kids, inner city kids, who live in the crowded conditions, or in the old houses, Section 8, where there's mold in the house. No matter how many nasal sprays we use, nothing works because they're constantly in the environment where their upper airways are subject to irritation. And I can't emphasize how important the environment is.
Mm-hmm.
We also find that carpeting and mostly mold. I mean, it's so hard I have to write letters to the landlords begging to maintain apartment, but in a proper condition. And unfortunately, it's not always working. So on a given day, I could see a child who gets the best dental care and the best orthodontic care. And then the same day, I'll see the child who is just on Medicaid, who can't get access and lives in these conditions that not a single spray will do anything.
Well, I think that we mentioned it before on Fireside Chats that a lot of places will have a year waiting list for a 3 or 4-year-old who has severe early childhood caries to get actually treated in many parts of the country, because it's an epidemic too right now. That the level of severe early childhood caries has gone up. But yeah, mouth breathing affects that. And so it's actually kind of a warning sign when I see a child come in who's young, has lots of decay and bruxism, and you'd start talking about sleep and everything, and do they sleep well? And they go like, oh yeah, we probably have another. It's like the Karen Bunnock studies, right? Which was looking at those little kids, 18 months of age, published in Preventing Chronic Disease from the CDC, and then being able to predict behavioral problems at age 4 and age 7. Remember all those famous studies? And we often refer to that research as being eye-opening. Although, I mean, we've had our eyes opened a few times, haven't we, for all this with sleep medicine?
I was curious what you think about the recommendations from American Academy of Pediatrics to apply fluoride by the pediatricians. Apparently, it's part of the standard recommendation now that in Bright Features, that pediatricians should be trained how to apply it during the well visits. Do you see it in practice that pediatricians do it, or do you see their better results?
Yeah, I have an issue, because when we do it in dentistry, we have suction. We apply it properly, and we have lights, so we know where we're putting it. And I'm going to get myself in trouble now. I always do. But I always refer back to literature. If you look, and we have a couple questions that have come up we have to get back to. So, Jillian, if you can share those with us toward the end. But if you look at the literature with fluoride varnish application under the age of preschool, it's not very effective.
That's disappointing. How come?
It's not very effective. And it's because it doesn't stay on. They consume it. It comes off. Now, sure, I can do it in my office because I know how to do these things, and my team members do. And we know how to apply it. We know how to protect it. And we keep the patient from taking it off with their tongue and picking it off with their finger right away. But moment those kids get in the car, they're out there picking it off. And then they swallow it. So you get the worst. You get the systemic ingestion, which you don't want, and you don't get the topical application, which you did want. But I'm not making that up. You can look at the review of the literature on that. Under the age of 5, out of 9 studies, only 7 showed a benefit. Or maybe it was 6 out of 9. But in the others, the benefit was kind of questionable, except for 1, because the fluoride varnish group also got better instructions on hygiene. They didn't quite have the study done correctly. So yeah, I know people get mad when I bring that up, but there's a limitation that heck, it was working so darn good. Why do we still have a great increase in the severe early childhood caries? I mean, obviously, you know, it doesn't take a genius to realize if you keep doing the same thing, it doesn't work. It's not working.
Do you think the pediatricians and parents maybe need to know about the timing of brushing teeth? I guess I ironically made a recommendation to brush teeth after breakfast, but I know that's not accurate. Perhaps I'm not the only person who gives incorrect advice to the families. What would you recommend
Well,
to the teeth professionals?
there's been so many issues with that too, because I've seen how some of the parents brush the kids' teeth. And don't forget, in my office, we had toothbrushing instruction areas where the parents would actually bring their child back and we would watch them brush the teeth because we had all these sinks set up, toothbrushing areas specifically for instructions and toothbrushing. And they didn't do a very good job. I mean, the parents were like, I'm done, and the kids would swallow all the fluoride toothpaste. And according to the CDC in 2020, October, I think, 2019, maybe October 2019, 40% of young kids are getting too much fluoride. It was 38 point some odd percent of young kids are getting too much fluoride. That's according to CDC. And the source was swallowing fluoride toothpaste because parents were putting way too much on when they're brushing the kids' teeth. So I'm sorry. That's not really the answer to our issue. You don't get cavities if you don't eat sugar.
It's as simple as it is.
Yeah.
We'll just cancel Halloween.
No, you can have Halloween, but don't have Halloween every day.
Yes.
And the problem is we're having Halloween every day, and we have huge concentrations of carbohydrates in a lot of our food. Everyone who knows me knows I've been railing on this for a very long time. Added sugar should not be added to anything except for sugar. It goes into specific treats. And I've had parents come in and tell me, I'm one of the old guys used to do diet counseling in the office. Used to be required to be a pediatric dentist when you got your diplomate status. You did diet counseling. And we have our little diet things. Oh, yeah. It used to be back in the old days, back when we used to have the posters up and showing how evil sugar is. It causes weight gain, causes diabetes. Actually, it predisposes you to cancer, too. There's a lot of good research on that. There's all sorts of problems with sugar. And we used to tell people, you don't see that done anymore. They don't talk about sugar anymore. I mean, sugar's the problem. And that's what Julie Way showed actually on that thing, is mostly removing the sugar from the processed foods and just going with more natural. Don't give them a fruit roll-up. Give them a piece of fruit. It reduced the need for surgery significantly. But hey, a couple of quick things. Going back to orthodontics, there's going to be a lot of people asking us questions about orthodontics and working with the orthodontist. How often do you refer to an orthodontist or a pediatric dentist for taking care of the issues?
Quite frequently. And I build my own referral list. So I try to have a representative in every single geographic area. So I have my list of, yes, all the time. And I wish we had few in our team so we could have a multidisciplinary clinic. But yes.
Yeah.
And I actually visited some of this orthodontist office before I include them in my list to make sure that we are on the same page and just to make sure that they're up to date. Or at least talk to them on the phone.
Yeah, you gotta make sure that they're actually treating to fix the airway issue.
Right. And
I've got some great slides on that, by the way, where they're doing a great job expanding, but at the same time they're expanding the posterior, they're retracting all the anterior teeth, and so you're just pushing the tongue right back, and you go like, oh, please, dude, you're treating airway.
And sometimes we get referrals from offices where parents would come with a child, and the child would get all these 3D images, and the orthodontist or the dentist would say, your child's airways are so small, and they panic and they go see a sleep physician. And again, we talk about the complex relationship of the size of the airways, their flexibility, that the size itself doesn't necessarily mean that the child is going to experience sleep apnea. So it gets a little tricky. Having said that, we actually established relationship with the clinic at Rush that has they have an oral facial surgeon and the orthodontist working together. So when we are unable to refer to our specialist, I send them to Rush.
Yeah,
which I know I'm not supposed to say, but that's the truth.
Yeah. See, that's the thing about testing, and we have all that CBCT capability now, and there's been studies done with the MRI too, to reduce the radiation developing of the airway, but everyone seems to be an individual. When I got started with testing on that, my first was when I started at Children's, we were doing the lateral cephs to look at the adenoids for airway and doing the Linder and Arison measurements. And that was back in 1978. I think that first paper came out, in 73, something like that? Because I remember knowing about before I started the residency. We've come a long way from doing the lateral ceph. Again, that was just an idea. I mean, if they had very giant adenoids, that could be a contributing factor.
We still do it sometimes because looking at the adenoids with a scope in the office is not fun. Kids don't love it. So how do you know the adenoids are enlarged? You just get the X-ray sometimes.
Yeah, and again, looking at the patient, I had a new patient come in. It was really funny. The young man is the son of a former person who worked in the office, who's now has her own practice. And I walked in the room, and I've known her for a very long time. Took one look at him. I go like, oh boy, has he had a sleep study done? It was so obvious. And she looked at me. She goes, no, but he needs one. Goes, he's a terrible snorer. He has all the symptoms. She goes, he's got all the symptoms. I go, yeah, well, he does. Absolutely. So you do refer out, and what typically do you expect back? I mean, Stephen Sheldon and I had this discussion back years ago, how I would love to be able to do prospectively a study, get the sleep study done, do the orthodontics, do a sleep study again, and then like a few years later, do another one just to double check to make sure we were actually treating the issue. He laughed. He goes, Mark, who's going to pay for all that?
Well, yeah, that's the unfortunate part. But what do we expect back? We hope to have ongoing conversations. So I would love to hear back from the orthodontist to get a copy of the consultation. That's my hope. And I think the expectation the other way, it's a two-way street, right? I refer you, hope together. And then kind of keeping up to date to see, okay, we finished the expansion. I would bring the patient back to the office or have a telemedicine visit to get clinical assessment, whether or not symptoms improved clinically, and then decide if sleep study is necessary or not. So when you get to know your referral base, then you kind of get this report, and then we work together. So it's a very gratifying experience when we have this kind of ongoing collaboration, and the families are usually very happy too.
Yeah, so far, I think I know a Jim Metz study that he did with high resolution pulse oximetry before and after treatment, but there aren't very many studies, and they're all being done with HSATs. I don't know of any major study. Maybe you know of a couple that have been done with the full sleep studies and everything.
I mean, we looked at the pulse oximetry as a screening tool for sleep apnea in kids. It turned out to be a great it has a very good specificity, but not a very good sensitivity. In other words, if it's very abnormal, it's very abnormal and it's suggestive of sleep apnea, especially when there are kind of intermittent dips, not just consistently low oxygen level. But if it's normal, it doesn't really rule out sleep apnea because many kids don't necessarily drop oxygen or drop it enough to pick it up by pulse oximetry. So I think it's a nice screening tool for really severe cases. But if it's negative, then you're kind of back to square one.
Yeah, I know. That's been kind of like, sadly, my experience. I have feelings that with some of the systems I've used that I'm missing cases. And but sadly, these are cases where, if I could get them in to see you, we would have done that. But that's just the way it is. What you mentioned, Academy for Sleep Medicine. Now you're a member of the American Academy of Sleep Medicine, correct? Yeah, yeah. Is that the one you're referring to?
As far as the recommendations for the tarnish,
for the no, for like, if you want to join and learn more, if you're really serious about sleep, let's say there's somebody out there who says, I want to learn a lot more about sleep
National Sleep Foundation is probably the best organization to join because it's open for non-medical professionals and they do a really good job. And Dr. Sheldon is actually on board. He's a board member. So I think the National Sleep Foundation is a reputable organization that provides a lot of education and a lot of opportunities, including volunteering, as far as I know. So I would highly recommend exploring that opportunity.
Yeah, I met a guy who is the head of the Italian sleep medicine group for patients. He's a lay person and suffered terribly with sleep apnea. And he has a very, very busy group of very large group of patients who've gotten together, and they're there for support of each other. And they have some, I guess, excellent speakers come in who talk to their group about this is what's newest in sleep apnea and sleep medicine.
I'm not aware of a specific pediatric group, but the National Sleep Foundation is more just in general for across all ages. I'm sorry, I think there are some questions. Oh, here we go. Thank you so much.
Yeah, there was a question on Inspire and in pediatrics, and you did mention that maybe there's a lot. We know a lot about Inspire, by the way. We get stuff about Inspire all the time. And a lot of us have attended classes.
Very expensive, I'm sure they advertise.
Yeah. We've attended classes and witnessed surgeries and done the whole thing, all of us. But pretty much, I think almost all of us have. But yeah, the question is on pediatrics. Because, again, that's a surgical intervention. And I'm so defensive of kids. I'm always worried when we start doing surgery on kids.
We don't use it yet for kids, but I know that there is a multi-center study that is exploring use of Inspire in younger kids, 13 and older, with Down syndrome. I'm not aware of any studies done in other pediatric population subpopulations, as far as I know, at least.
Okay. And then there was a question, Jillian, can you bring it back up? Someone had a question about, with a mom of a child, I suspect a sleep disturbance. She said he's a great sleeper and that he falls asleep quickly at bedtime.
It would be nice to have a little bit more history and to get some sense how many hours of sleep the child gets. The child may fall asleep but not remain asleep. Quality of sleep. What we're really lucky is that we really appreciate technology as parents. A lot of frequently now have cameras that can provide us with little video clips. We can see that some kids seemingly sleeping but flipping and flapping and moving. So good history and a little bit of maybe a video feedback would be helpful without even a official sleep study to get some sense whether or not the schedule is consistent, the hours of sleep, whether or not sleep is interrupted. That probably would be my best suggestion. It's hard to make any judgment call with that little information, but possibly, the child may not be getting good quality sleep.
Yeah, you bring up that, and there's a couple apps you can get for your phone too, like Sleepwatch and others that listen for the sounds of sleeping. And I had a lot of fun with. I had to do some cat sitting for my oldest son, who was unavailable because of doing a lot of exams. So I used it to record the sound of his one cat snoring, who obviously has sleep apnea.
Yeah, I've heard the bulldogs are the biggest. Unfortunately, I mean not cats, but dogs. Among dogs,
The
bulldogs are
bulldogs
the
are.
biggest sufferers of sleep apnea.
Dr. Trostman, thank you so very, very much. It's been such a pleasure. We've had I think, a wonderful discussion on collaborating together. I know you do a wonderful job um, working with orthodontists and the ear, nose, and throat. And I really, really appreciate very much you taking this hour out to just have this little friendly chat with us. And guys, if you have any more questions, you know we're at Lori's, right?
Right.
Of course, I'm in the Oval Office at Lori's right now. Yeah. So
Yeah.
they should make me president of the hospital. Seriously, right?
Right.
And
Well,
here again, it's time for us to end our presentation and for us to inspire our colleagues, our team members, our patients, and all those that are influencers. Think about sleep apnea, be aware of sleep apnea, sleep disturbed breathing in kids. It's actually pretty common according to the epidemiological studies. And I want to thank you all for listening. And then we do this because we want to save lives. I mean, I just kind of wish I had known my younger brother was going to pass away from sleep apnea. He was only 59 years old.
it's heartbreaking.
Yeah, he
Thank you
has.
so much for inviting me and making it so easy. It was
Oh,
really
well, you're
wonderful.
welcome. I
Your
have to
time.
do a couple reminders before we cut off, though. So, March 8th, Fireside is with none other than Dr. Alan Reisinger, and we're going to talk about collaboration with all of our colleagues there. And he's going to discuss a whole body approach to healthcare. Yay. It's like the old joke we have when the dermatologist discovered 3 years ago a shocking finding. The skin was attached to a body. They joke about because now they know by looking at the gut microbiome, we can actually diagnose without seeing the patient if they have eczema or certain forms of acne and, of course, psoriasis. And then he's going to talk about whole body approach to healthcare, especially concierge medicine and VVIP in particular, aggressive cardiovascular prevention, and the whole oral systemic connection. And then on March 23rd, we have cardio diagnostics with Dr. Robert Philibert. Don't miss that one. Don't miss a beat. That is the latest in cardiac diagnosis. Know before it's too late. That is a very interesting. I've done cardio diagnostics. It tells you a lot of information. And August 5th, we have none other than my friend, Dr. Tom Neighbors. I think a lot of you know him of his great research. And then May 17th is the legendary Dr. Jeffrey Hillman from Foresight. So, and hopefully my good friend Marty Hanfield will be with him too as a guest. So don't forget those dates. And thank you again, Dr. Trostman, and everyone have a wonderful evening.
Good night. Thank you.
Good night, everyone.